Good morning and welcome to the Committee on Women and Gender Equity, jointly with Health. At this time, we ask you to please place phones on vibrate or silent mode. Chairs, we are ready to begin.
Good morning and happy Valentine's Day. I am Councilmember Farrah Lewis, Chair on the Committee on Women and Gender Equity, and I'd like to welcome everyone to our joint oversight hearing with the Committee on Health, addressing disparities in women's health. I'd like to thank my phenomenal colleague and Chair on the Committee on Health, Councilmember Lynn Schulman, for her partnership to hold this important hearing today. Gender biases in healthcare is a prevalent and extensively reported problem that often results in unfavorable experiences and adverse outcomes for women in our city, particularly women of color. The International Journal for Equity and Health reports on the underlying myth that bodies assigned male at birth are somehow superior to those assigned female at birth. In addition, such myths are about biological sex are also those around race, which inaccurately ascribe physical, mental, and emotional qualities to individuals based on race. This misconception has substantial effects, consequences, and ramifications for girls and women of all ages, including significant gaps in medical and clinical research, insufficient testing, misguided diagnosis, and even inaccurate treatment plans. In addition, misconceptions around women's sensitivity to pain and exacerbating pain persist, even among non-male physicians. And as we observe Black History Month, I would be remiss if I did not highlight that studies show that Black women have reportedly been routinely taken less seriously in healthcare spaces by their physicians, and by their physicians than their white counterparts, therefore much less likely to trust healthcare providers. Biases in healthcare provision not only perpetuate harmful stereotypes, but also result in women and gender expansive people avoiding medical care or receiving inadequate care, which further negatively impacts their health outcomes. Ongoing implicit bias and racial disparities in healthcare in New York City are alarming. And as a Black woman, I am deeply concerned about this particular issue. We must recognize that while we'll highlight and draw attention to gender inequities in this hearing, many of the challenges that women face will persist until we take aggressive and effective action to address them. Today, we'll be taking a broad look into the leading causes of death among women in the United States and in New York City, which include cardiovascular disease, cancer, chronic lower respiratory disease, and Alzheimer's disease. We look forward to hearing more about the leading health issues facing women in New York City and the disparities and challenges that women experience accessing preventative health care services. I would like to thank the representatives from the Department of Health and Mental Hygiene, advocates, and members of the public who have joined us today. I would also like to thank my staff, Blake Shaw, Phil Marius, Daniel Heredia, as well as committee staff, Committee Counsel Sahar Mozami, and Senior Legislative Policy Analyst Christy Dreyer for their tireless work on this hearing. And now I'd like to turn it over to my colleague, Chair Schulman, for her opening remarks.
Thank you, Chair Lewis. Before I begin, I want to acknowledge that we've been joined by Council Members Menon, Narcisse, Marmorato, and Vernikoff. Good morning, everyone. I am Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. I want to thank Chair Lewis and the Committee on Women and Gender Equity for joining with me for this important hearing today. Today is Valentine's Day, and there's no day more appropriate to focus on matters of the heart, and more specifically, heart health. The committees today are shining a light on the most urgent health issues facing women in New York City and in the United States, including heart disease, which according to the CDC is the #1 health issue facing women in our country. We also hope to discuss any efforts the city is undertaking to address the disparities that women face in the areas of cancer care, chronic lower respiratory disease, and Alzheimer's, all leading causes of death for women in the United States and among the leading causes of death for women in New York City. Persistent gender bias in healthcare has resulted in inadequate access and treatment for women across the country. Studies have consistently found that some healthcare professionals continue to view women as emotional or hysterical and are more likely to attribute their symptoms to a mental health condition rather than a physical condition. Misconceptions around women exaggerating pain persist to this day, even among non-male physicians. Biases in healthcare provision not only perpetuate harmful stereotypes, but also result in women avoiding medical care or receiving inadequate care that negatively impacts their health outcomes. As a breast cancer survivor and as chair of the Committee on Health, I am committed to ensuring that every woman in New York City has access to quality preventive care, including regular screenings. Health care is a human right, and the city must work with our state and federal partners, healthcare providers, community organizations, and advocates to eliminate disparities among women when it comes to identifying, diagnosing, and treating cancer. Social, environmental, and economic burdens contribute to the wide gaps in cancer outcomes for women as compared to men and for non-white women as compared to white women. For example, in 2021, the rate of premature death from cancer was about 41% higher among Black New Yorkers compared to the citywide average. Eliminating these disparities requires a comprehensive approach and critical investments in public health. Last week, the Council unanimously passed my bill to codify the Healthy NYC citywide population health agenda to increase average life expectancy in New York City to 83 years old by 2030. As part of this goal, the city aims to decrease heart and diabetes-related deaths by 5% and screenable cancer deaths by 20% over the next 5 years. To do this, the city will increase healthcare access, expand prevention activities, and improve access to healthy foods. The plan also calls for reducing toxins in our food supply, preventing tobacco use, and reducing smoking and alcohol consumption among New Yorkers. I look forward to a sustained partnership between this council and the administration to realize and build on the goals of Healthy NYC and create a happier and healthier city for all. Valentine's Day is about honoring those we love, and that includes love for our communities. Community care should be at the center of how we address glaring health disparities for women and reduce the incidence and impact of chronic disease. I'm hopeful that today's hearing will generate thoughtful discussions and bold ideas for advancing equity in women's health. In closing, I would like to thank Dr. Morse for attending, as well as my staff, Chief of Staff Jonathan Boucher, Legislative Director Kevin McAleer, Legislative Fellow Andrew Davis, my Communications Director Jessica Siles, and the Health Committee staff, Christopher Pepe, Sarah Sucha, and Manor Butt, for their work on this important hearing. I will now turn it back to Chair Lewis.
Thank you, Chair Schulman. Now we'll turn it over to Committee Counsel to administer the oath.
Thank you, chairs. Good morning, everyone. As a reminder, today is an in-person hearing with the option of virtual testimony for the public. The committee will be accepting registrations for testimony throughout the hearing. For those wishing to testify in person, please see the Sergeant-at-Arms in the back of the hearing room to fill out a testimony card, even if you registered in advance online. For those testifying via Zoom, your name will be called and you will be prompted to unmute. All those who wish to submit testimony, you may do so at testimony@council.nyc.gov. We will now hear testimony from members of the administration. Will you please raise your right hand? Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions?
Yes.
Thank you. You may begin when ready.
Good morning, Chair Schulman, Chair Lewis, and members of the committees. My name is Dr. Michelle Morse. I'm the Chief Medical Officer and Deputy Commissioner of the Center for Health Equity and Community Wellness at the Department of Health and Mental Hygiene. On behalf of our Commissioner, thank you for inviting me here today to speak about inequities in women's health in New York City. While disparities and inequities are often used interchangeably, throughout my testimony, I will be using inequities instead of disparities to highlight the term inequities because it reflects the reality that the gap that we see in health outcomes today are the result of avoidable, unfair, unjust systemic policies and practices in our society that can be changed. The Health Department addresses health and social inequity across New York City in partnership with community, faith-based, and healthcare organizations. The department's work focuses on social determinants of health, such as housing and economic status, as well as environmental and commercial determinants, and addresses both upstream and downstream factors to improve the health and well-being of New Yorkers. In 2021, the New York City Board of Health's resolution declaring racism a public health crisis highlighted the long history of structural racism impacting services and care across all institutions. Structural racism is a system that excludes, marginalizes, and harms Black, Indigenous, and people of color across New York City through discriminatory housing, employment, education, healthcare, criminal, legal, and other systems, all of which result in avoidable and unjust health outcomes for chronic disease and many other illnesses. The New York City Health Department works to eliminate racial inequities in health outcomes and premature mortality, which is defined as death before the age of 65 years. I understand the committees have expressed interest in addressing the leading causes of death nationwide for women noted by the Centers for Disease Control, including heart disease, cancer, stroke, chronic lower respiratory disease, and Alzheimer's disease. I'll be addressing these topics, as well as the impact of diabetes on women and the New York City Health Department's ongoing efforts to address these issues. Of note, in New York City specifically, the leading causes of death for women in 2021 were heart disease, cancer, COVID-19, chronic lower respiratory disease, and Alzheimer's. It's important to note that February is both Black History Month and American Heart Month. These designations help bring awareness to the historical and systemic issues that contribute to the inequities that we're discussing today. The city takes a comprehensive approach to addressing health inequities. The Center for Health Equity and Community Wellness itself was created to ensure a comprehensive and strategic approach to reducing racial inequities in premature death. As you know, heart disease continues to be a leading cause of death for women, while breast cancer is one of the leading causes of cancer death for women. Our analysis also shows that among women, rates of hypertension or high blood pressure are highest among Black women. A recent community health survey found that 42%, I'm going to say the number again, of Black women reported being diagnosed with high blood pressure, compared to 31% of Latino women, 25%. These inequities stem from a range of causes, including structural racism's impact on access to health, resources, wealth, quality of services, and the reality of clinical research being historically conducted with white men, as was already noted by the chairs, and with subsequent findings often incorrectly applied to women. In addition, cerebrovascular disease or stroke was the fourth leading cause of death in women. In our efforts to combat heart disease, stroke, and high blood pressure, the health department has developed innovative programs. We launched the Take the Pressure Off program in 2016, a hypertension initiative which takes a place-based approach to addressing inequities in high blood pressure. This program recently received a grant from the CDC to address high blood pressure in Brownsville, Brooklyn, which is a neighborhood where we have an action center that is highly impacted by inequities in cardiovascular disease, which you can see on the map to my left. Take the Pressure Off has taken a comprehensive community-based approach by linking a federally qualified health center, the BMS Family Health and Wellness Center, the Brownsville Community Culinary Center, NYCHA developments, and insurers to collaborate on improving hypertension awareness, management, and connection to care. Take the Pressure Off offers a Hypertension 101 workshop for community groups to promote awareness and understanding of hypertension. Over the past year, we've completed 45 presentations and train-the-trainer events. In addition to heart disease, we appreciate the Council's focus on cancer affecting women, since it's the second leading cause of death for women. In 2021, the rate of death from cancer was about 14% higher among Black New Yorkers compared to the citywide average. Specifically, breast cancer is one of the leading causes of death in women in New York City. In 2021, Black women died from breast cancer at a rate 41% higher than the citywide average. In our efforts to detect and treat breast cancer, the health department contracts with a mobile mammography van program to provide no-cost mammograms and patient navigation within the neighborhoods that have the highest rates of breast cancer mortality. The program aims to decrease barriers to care, such as access to transportation, insurance status, and ability to pay. In the past 18 months, the program provided screenings to over 4,800 eligible women. Notably, colon cancer, while not specific to women, is another area of focus for us. The New York City Health Department funds patient navigation services at 2 health service providers located in neighborhoods with the highest rates of colorectal cancer mortality. Patient navigation services enable timely screenings by providing education, support, and access to resources to reduce barriers to care for those who are uninsured or underinsured. We're currently working with partners through a committee hosted by the NYC Health Department on how to improve access to colonoscopy for patients without insurance. I now want to turn to Alzheimer's disease, also in the CDC's top five causes of death among women. The Health Department has a new program called Building Our Largest Dementia Infrastructure, also known as BOLD, which seeks to improve the health status and quality of life of New York City residents with Alzheimer's disease and related dementias, and of their caregivers. To achieve this goal, this initiative aims to create a diverse, multidisciplinary coalition which will include a wide range of stakeholders who recognize how structural racism and socioeconomic inequities have increased the risk factors for ADRD and worsened outcomes for a large proportion of New York City residents. Some of these risk factors include smoking, high blood pressure, diabetes, and obesity. In the coming months, we look forward to creating a plan that is data-driven, addresses social determinants of health, improves coordination, supports reduction in risk factors, and aligns with the CDC's Healthy Brain Initiative roadmap. Through this process, we also aim to increase awareness and understanding about the importance of risk reduction, early detection, access to quality care, and supportive services for affected individuals and their families. On chronic lower respiratory disorder, cases of asthma and related inequities are a significant area of concern. Children are an especially vulnerable population. In 2016, the rate of asthma-related ER visits amongst children ages 5 to 17 was more than 6 times higher in very high poverty neighborhoods compared to low poverty neighborhoods in New York City. Because asthma can have the most harmful effects on children, the Health Department has significant resources to address and improve these inequities we see facing kids and families across the city. Our Office of School Health provides various services for children in school, including medicine administration and education. Our East Harlem Neighborhood Health Action Center offers free counseling, education, and other support services for kids with asthma. And our Tremont Neighborhood Health Action Center offers cost-free pest control services for eligible families, and our Healthy Neighborhoods program provides free home assessments for kids and adults diagnosed with persistent asthma by a healthcare provider. While diabetes is not technically within the top 5 causes of death listed by CDC, it is an important condition to understand as we discuss health inequities in our city. Diabetes prevalence has increased over the past 10 years, leading to enormous harms to New Yorkers, including vision loss, blindness, kidney and nerve damage, heart disease, stroke, and amputation. Our data underscore the unfair burden that diabetes and related complications present to communities of color in New York City and communities experiencing high poverty. A critical tool to achieving reductions in diabetes rates is a long-standing successful evidence-based initiative known as the Diabetes Self-Management Program. As you may know, recent federal approval of changes to the state's Medicaid program would make the Diabetes Self-Management Program reimbursable through Medicaid, which would represent great progress if we ensure it's accessible by as many groups as possible. In addition, with the initiative from the Council, Local Law 52, passed in 2023, to develop and implement a citywide diabetes incidence and impact reduction plan will also be a critical tool in achieving reductions in diabetes rates. The Health Department leads a number of programs which aim to address the root causes of chronic conditions and inequitable health outcomes. Working upstream on cross-cutting issues like food and nutrition security, tobacco cessation, health insurance access, and others allows us to prevent disease and impact many of the top 5 causes of death altogether. On food and nutrition security, our Groceries to Go program provides eligible New Yorkers with up to $270 a month in credits to buy groceries. Health Bucks coupons can be used to purchase fresh fruits and vegetables at all New York City farmers markets. Our Shop Healthy initiative combats predatory advertising, which are often targeted towards communities of color. This program also increases the availability of healthier foods through counter-marketing strategies and relationship building with food retailers, distributors, and community members. We're also changing the food environment to be healthier through the New York City Food Standards, which are evidence-based nutrition criteria for all foods and beverages employers serve, and were developed to help lower the risk of obesity, diabetes, and cardiovascular disease by setting guidelines for any city government facility where food is served. We also do tobacco control initiatives because smoking is still a leading contributor to New York City deaths. Statewide, tobacco is estimated to kill 22,000 people each year. These deaths contribute to inequities in premature mortality. Finally, we offer health insurance enrollment and access through our Office of Health Insurance Services. Individuals with health insurance get more access to preventive care and are better able to manage chronic disease. Given this hearing's focus on inequities in women's health and the New York City Department's work to address the harms, it is critical that we address birth inequities and prioritize Black women and birthing people. Even when controlling for socioeconomic and educational status, Black women and birthing people are still more likely to suffer from severe morbidity and mortality. These inequities are rooted in racism and structural inequity. Contributing factors include decreased access to care, residential segregation, and stressors from experiences of racism. Our family wellness suites are integral to disrupting these systemic inequities and are part of the city's plan to prioritize maternal and infant health. Family wellness suites in Tremont, East Harlem, and Brownsville are physical spaces for families to receive services, health education, and linkages to community resources. They provide birthing people and their families a safe, welcoming, and supportive space to participate in a range of parenting and birthing classes, breastfeeding support, connect to community resources, and receive critical supplies like car seats and pack-and-plays. These sites are staffed by community health workers, doulas, lactation counselors, social workers, and other public health professionals. In FY23, the Family Wellness Suite served over 1,500 families across the 3 sites and distributed over 1,500 cribs and car seats and 43,000 emergency diapers. Finally, I would like to highlight the importance of taking a place-based and race-conscious approach to chronic disease, and this is highlighted on the map to my left yet again, showing the high rates of premature mortality in some New York City neighborhoods. This approach serves and greatly benefits women in New York City. The department's Public Health Corps program is an ecosystem of community health workers and community-based organizations supported by the health department to center the communities with the most unfair burden of disease, be it COVID or chronic disease. Again, these are highlighted in the map. As the public health emergency ended, we shifted this program to integrate chronic disease as a focus because of the extensive partnership, trust, and network we have built over the past 3 years. Community health workers now screen community members for social needs and chronic disease and make connections to health and social care. One community health worker shared this about the impact of their work. This work allows us to build trust with community members who previously had little to no exposure. This will allow us, we hope, to have relationships where the community trusts us as credible messengers for future health initiatives. This is a powerful insight that speaks to the importance of the role of community health workers in building bonds to create more healthy and equitable communities. I'd like to close my remarks finally, I know I've been talking for a while, by highlighting the need for a comprehensive approach to addressing these key drivers of premature mortality. In November 2023, the city launched Healthy NYC, a citywide campaign for healthier, longer lives. This effort will require public and private sectors to work together to reach our goals. I want to thank the Council and Chair Shulman for unanimously passing the legislation last week that will require the Health Department to have and update every 5 years a population health agenda. This will ensure that our focus and goals around creating a healthier New York City outlive any one administration. Further, the Adams administration recently launched Women Forward NYC, an action plan for gender equity, an investment aimed at making New York City a national leader on gender equity, including for transgender and gender expansive New Yorkers, with the ambitious goal of becoming the most supported through city dollars, private and public partnerships, academic institutions, and federal funding. This living action plan is a framework for all of the administration's efforts to addressing gender inequities going forward and taking immediate action to connect women to professional development and higher paying jobs, dismantle barriers to sexual, reproductive, and chronic care, reduce gender-based violence against women, and provide holistic housing services, including for formerly incarcerated women and domestic and gender-based violence survivors. New Yorkers can now revisit the relaunched women.nyc to support women and families. Thank you for inviting me to discuss this important topic. I'm happy to answer your questions.
Thank you. So I want to talk a little bit about women's health, just in general. We'll start there forward. How does DOH
that question, Councilmember Chairwoman. The New York State Health Department is a real partner in our work. The State Health Department have an impact on reducing health inequities. They are also the regulatory body for healthcare institutions across New York City. So we do work closely with our colleagues there. We have regular meetings and discussions around both regulatory comments that we provide, collaborative efforts with the stakeholders that the state brings together, and then with our staff counterparts in the state.
Thank you. What factors does DOHMH attribute to the disparities in the provision of women's health care, and what particular programming or initiatives does your agency conduct to address these factors?
Yes, thank you for that question. And again, we're really thankful for Council's interest in focusing on women's health and women's inequities specifically. We see many, many layers that drive the women's health inequities that New York City is facing. I think breast cancer is one of the most important areas for us to look at. Specifically, from our perspective, there are a number of reasons why we see so many inequities in both diagnosis, treatment, and mortality and outcomes for women around breast cancer. It, at many levels, is related to everything from access to health care, whether that's paying fees when you're going to get that health care, having the time to get your mammogram every year, having the primary care doctor who can help encourage you to do that, all the way up to things like not actually having reliable housing or employment, which makes doing things like an annual mammogram even more difficult. So this really gets at the social determinants of care as well. It's not only the health care, it's also the whole entire context of a woman or someone who identifies as a woman who needs to be able to get access to those different services. So we see lots of layers to the reasons why these inequities happen. I do want to highlight one breast cancer program that I mentioned in my testimony, which is really focused on the mobile mammograms and really bringing them to the neighborhoods where we see some of the highest rates of breast cancer mortality, with the goal of really reducing as many barriers as we possibly can.
Thank you for that. I forgot to mention that we were joined by my colleagues, council members Caban and Gutierrez. Back to programmatic services. So I wanted to ask you, in addition to the mobile mammogram services you provide, what additional programs are designed for women through DOHMH, and how does it also include women with disabilities?
Thank you for that question. The breast cancer mammogram program is one of our main programs right now for breast cancer specifically. I would say that many of the healthcare systems and institutions across the city also have specific breast cancer programs and outreach programs for preventative care, and our colleagues at sister agencies are involved in many of those programs as well. In terms of our focus on women with disabilities, I think that that's an area that we can follow up with you on and share some more resources on what we do in that particular realm.
Thank you. So I just wanted to quickly ask about the mayor's new women's health agenda. In January 2023, Mayor Adams announced the New York City Women's Health Agenda, now called Women Forward NYC, aimed at addressing the systemic inequity that women often experience in healthcare and in other areas in their lives. This agenda stems from the city's first ever Women's Health Summit that you all held, which convened more than 100,000 experts across various health sectors. So I wanted to ask, how did DOH-MH decide which health issues to focus on regarding this agenda?
Thank you for that question. The health department is involved in the Women Forward agenda. We are one of multiple different sister agencies who are involved, and City Hall led the action plan, but I can speak to the health department parts of it specifically. One of the ways that we contributed towards the plan was that we looked at some of our health outcomes and health data that we do surveillance on across the city, and we looked at some of the biggest drivers of preventable illness and death for women and girls, and we also looked at what are the most egregious inequities as well. And this led us to suggest a focus on 4 key areas to make New York City more healthy for women. So those areas are around reducing pregnancy-associated mortality among Black women by 10%, reducing breast cancer mortality by 10% with a focus on reductions for Black women, increasing the percentage of 13-year-olds with completed HPV vaccines by 40%, reducing the annual HIV diagnosis rates for Black and Latino women by 50%, and reducing the percentage of public high school girls who report feeling sad or hopeless by 10%. So those were some of the areas that our data told us should be areas of focus because of the level of inequity.
Thank you for that. And did you also include the data identified by the CDC as the leading causes?
That's a great question. We looked more at New York City specifically, but I think the overlap is 100% with the CDC priorities as well.
And research shows that BIPOC women, and particularly Black women, are more likely to have poor health outcomes due to disparities in care. How is this agenda highlighting that issue and ensuring that it is focusing on the most marginalized women? You highlighted some of it, but if you could go further.
Yes, thank you for that question. We very much agree that we need to be focusing our resources on the communities and populations that have the most unfair outcomes. And so the way that we do that is something called Centering the Margins. It's a program design tool that is focused on anti-racism, and it's about prioritizing women of color who have the most unfair health outcomes, and knowing that by targeting and focusing on that population, outcomes for everyone will actually improve. So specifically, I want to also highlight Brooklyn Borough President Antonio Reynoso's maternal health task force that we participated in, and that led to a focus on communications campaigns, giving information about nutrition, emotional wellness, legal rights, health insurance access, midwifery support, and doula services. We also have a midwifery initiative that builds on research about existing midwifery care models across pregnancy, birth, and the postpartum period. We also run the Maternal Hospital Quality Improvement Network, which is a clinical and community initiative that seeks to reduce inequities in preventable maternal mortality and morbidity with a focus on Black women. And then finally, we also run the Citywide Doula Initiative, which provides doula support citywide through the By My Side Birth Support Program and partnerships with other doula-led organizations. So those are a few of the programs that really focus, again, on the inequitable and unfair health outcomes of Black women.
Thank you for that. You mentioned a bill that maternal health package that we worked on last year. So I wanted to quickly ask you about 2 bills that we got passed last year and for some updates. In 2022, one of my bills, Intro 482, was enacted requiring the Department of Health and Mental Hygiene to provide education on polycystic ovary syndrome and endometriosis by posting information on its website, including but not limited to definitions of potential symptoms of polycystic ovary syndrome and endometriosis. I wanted to know if you could provide the committee with an update today.
Yes, thank you so much for asking that question. At this moment, I don't have information on an update on that specific bill, but we can follow up with you with more information.
And another bill that we got passed in 2022, Intro 409, was enacted requiring the Department of Mental Health and Hygiene to post the annual maternal mortality and morbidity report on its website. As you were sharing earlier, this is something that's within the agenda that the mayor put forward. Can you share a few words on that?
Yes, just this past September, we did post the updated data and rates around maternal mortality. That is available on our website now, and we can share that information in follow-up, but that was released this past September 2023.
Thank you. And besides the borough president that you mentioned, what other organizations and advocates are you working with and developing these programs for the agenda?
Thank you for that question. One of the things that we see as critically important is to make sure that the voices of the women who've been directly impacted are central to how we design our programs. One of the ways that we've tried to do that is through developing our own health department, Brooklyn Birth Equity Working Group. This is a part of one of the initiatives that I've been leading as Chief Medical Officer. That working group has almost 40 members that are all in Brooklyn and are focused specifically on all of the different parts and sectors of society that have a stake in reducing maternal mortality. Brooklyn is the largest borough by population, and it has the largest number of maternal deaths proportionate to population as well. And so that's part of the reason we focused there. And one of the things that's being done as a part of that working group, the members of it include doulas, community-based organizations, healthcare organizations, insurers, community members, health department staff, as well as some of our sister agencies, including Health and Hospitals, ACS, and others. And what we're trying to do is really use a collective impact approach, because this is both a social and a healthcare issue. And what we want to do is continue to reduce Black maternal mortality. As described, the goal for Healthy NYC is to reduce it by 10% by 2030.
Thank you. I'm going to hand it over to Chair Shulman.
Thank you, Chair Lewis. First, I want to acknowledge that we've been joined by Council Members Ariola and Riley. Good morning, Dr. Morse. So I have a few questions, but let me start off this way. Your testimony was extraordinarily substantive. So you've set the bar for your colleagues, whoever's watching in the admin. So with that, a few questions. One is, you mentioned during your testimony about the bill that was passed about the plan for diabetes. I know that that plan is due sometime in the spring. Can you give an update on where we are with that?
Yes, we are actively working on that plan. I can certainly share a little bit more of a progress report in follow-up, but our team is working with the working group that was convened to develop and influence that plan.
Okay, looking forward to that. When you talked about the mammogram van, like how often does that go out? How are the arrangements made for where it goes? Can you just give some background and details on that?
Absolutely. The partner that we work with who sends out the mobile vans, what they do is they work with the community-based organizations that we partner with already in the neighborhoods that have the highest rate of breast cancer mortality. They contact those community-based organizations. They describe for them and ask them what are some of the dates and locations, host locations, that would be willing to host the mobile van. Then what they do is actually develop materials that the community-based organizations and other partners, including elected officials and other partners in those communities, can send out to let women know in the neighborhood know the date that the van will be present on that particular site. And then they also do street outreach when they're doing the mobile van screening. And then they host the mobile van screening for up to 20 women, at least a minimum of 20 women, for the date that they are doing that particular screening site. And then for any women whose mammograms are positive, they also have navigators who help navigate those women to the appropriate care that they need. So I think that's the main process, but we can share more information.
Yeah, I'd like to get information on where you do it and when, and all of that, because I want to see how I can partner, and those of us in the council can partner on that, because that's something that's very important. I will tell you that when I was diagnosed with breast cancer, it was during COVID, and there were, it was during a routine screening that I pushed myself to go to, but I will tell you, I met women who, because they had lost their jobs during COVID or whatever else, didn't get screened. So I just want to see where we can go, because I do have a part of my community that has a great need. And also, I presume that you do it in culturally appropriate ways. So, because there are a lot of, I will say, there are women that are certain demographics that are afraid to go for screenings, or they're not used to it, or they take care of the rest of the family, and they don't, if something bothers them, they don't bring it forth. So, those are the kinds of things, the inequities that I want to try to address as well.
Thank you for
in
that.
terms of colon cancer that you mentioned, just describe for me sort of what you guys are doing in terms of getting people screened. So one, I know there's colonoscopies, but there are also measures that can be taken. There are these new tests now and things like that. Is there a way that we can help the Department of Health get some of these for women, at least for an initial assessment, and then go from there? I mean, I want to, for me, and I'm part of, as you said, Healthy NYC, and we codified that plan in legislation. I'm going to say something now. I'm a lazy patient, all right? So I am. But that doesn't mean I don't care about my health. We have to establish protocols and standards where, people get up in the morning, they go to work, they come home, basically. I'm being very basic here. But we need to meet people where they are and try to get them something that at least can move them forward. Not everybody has a primary care physician. That's a whole other issue that I'm not going to address today. And so just tell me sort of what you guys are envisioning for that.
Thank you for that, Chair Shulman, and I wasn't aware of your diagnosis, but thank you for sharing that personal experience. And I do want to also just mention my team just shared that we had 14 events for the breast mammography van back in December of last year. So we are happy to share more information about that and follow up with you. For colon cancer specifically, we have for over 20 years now led a coalition called the C5 Coalition. That coalition's focus, it brings together healthcare organizations, cancer specialty centers, researchers, health department staff, and really tries to look at population health level interventions to reduce mortality from colon cancer and to increase screening because timely screening is so life-saving, as you highlighted. For colon cancer, the recommendations are that anyone between age 45 and 85 are screened. And there are multiple methods for screening, as you described, including stool tests in addition to actually having a colonoscopy. Part of what we try to do when it comes to colon cancer access is we actually have patient navigator programs as well around cancer care. And the RFP that we use to try to engage community partners and fund community partners around cancer specifically are really focused again on the neighborhoods that have the highest cancer mortality. So part of the way that we also do the screenings is by educating providers. As you're probably aware, some of the providers, it can be hard as a physician to keep up with the changing guidance. Right. So we also do public health detailing, where we go out to primary care practices all across the city and specifically in the neighborhoods that have some of the most unfair health outcomes. And we talk with those providers and give them patient education materials in multiple languages, and also give them other information about the updated screening recommendations. Now, even with all of that, as you described, it can be very difficult, particularly if you have 2 or 3 jobs, if you're a caretaker, if you're a parent, if you have unstable housing or unstable employment, all of these other factors make it very difficult to do screening regularly. So part of the way that we try to address that is through enrolling. We have a whole entire office dedicated to enrolling New Yorkers in health insurance, which is one of the ways to help at least decrease the cost for the screening. And there are many of our other healthcare partners who are doing other outreach and events around colon cancer and other cancer screening. But I would admit that we can always do more. I will also say, however, that C5 coalition over the past 20 years has really reduced some of the preventable colon cancer mortality, which I think is a very important outcome.
And a question, my understanding is that in communities of color that the age is lower in terms of colon cancer, is that correct?
So it's a very important question. Some of the guidelines from the U.S. Preventative Task Force have shifted and have started to consider things like race in the guidelines for when screening should start. I think conversations are ongoing about when that shift should happen, but yes, in some cases, race, and specifically Black race, is a factor, as well as family history in deciding if screening should start earlier than for the rest of the population that may not have those risk factors.
And it seems to me that women are younger now that are getting breast cancer as well, so.
We can, the guidance was just updated to recommend breast cancer screening starting at age 40, and we can definitely share more information about how we've updated our patient education materials and guidance based on those changes in the recommendations.
Okay, so I want to ask a couple of questions about heart disease, and I want to also acknowledge we've been joined by Councilmember De La Rosa. So heart disease continues to be the leading cause of death for women. What steps are the city and DOHMH taking to ensure that women in New York City have access to heart healthy practices and quality medical care, particularly in terms of prevention? And then I'm going to have a follow-up to that, but go ahead.